and Bangladesh. It's just wonderful. Like I feel like I'm on a cloud, like moving around different parts of India. It's so wonderful, and of course we are very happy. At the same time, we are very nervous because I hope this entire session goes without too much of glitches. And I hope that I'm audible to all of you clearly in real time.
Raise your hands if you are audible.
Thanks.
Could you raise your hands if you all want to? Okay, good. Thanks.
Yeah.
Okay, so this is the first eco in palliative care in India. So it's a great feeling to have this happen today. We are sort of familiarized with each other, but let's begin by introducing once more because some of the members may not know others, but we'll keep it very brief. Just our own name, the center, and the place that we are from. Okay, so we'll begin from the hub. I am Dr. Nandini, and this is the Rajagopal Institute. And several of my colleagues here. Of course, Dr. Rajagopal is all of your teacher. Dr. Sam Manikyam is a clinical psychologist. Dr. Anne Broderick is a visiting palliative care from Sridevi is here with us. She is the staff physician here. Just turn the camera a little. So we also have Sister Shiva here, who's a senior nurse from our center, and this is Sherry. She's the medical social worker from our center. So I move on to Vidya Kumaraswamy now, and she from that row we will start. So Vidya, please introduce yourself.
Yeah, I've been communicating with everyone through the emails. It's nice to see everyone join us. I'm Dr. Vidya Kumaraswamy. I'll be your coordinator for the session. There's another Vidya, which is Vidya Vishwanath. Kindly don't confuse between us two. Thank you.
Maya?
Ma'am. Maya, can you introduce yourself? You have to unmute.
I have already unmuted, Dr. Vidya. Am I audible?
Yes.
Okay. Hello everyone, I am Dr. Mayank. I am from SDRR Medical College, Dehradun.
Welcome. Vidya Vishwanath.
Hello, this is Vidya Vishwanath. I'm from Homi Baba Cancer Hospital, Visakhapatnam. And this is Roja, a staff nurse, our technical assistant.
Yeah, sorry, you're not audible. Can you speak up?
All right, I'm Vidya Vishwanath from Homi Baba Cancer Hospital and Research Center, Visakhapatnam. And right here is Roja, our nurse who assists in palliative care, our technical help, Lalitya, and we have our surgeon, Dr. Chandrasekhar, with us. And we will have a couple of people who will join in and out. Thank you so much.
Welcome. Abhishek.
Good afternoon, everyone. I'm Dr. Abhishek, working as a palliative care physician in CanKids. I also work as advocacy officer for Pallium India. I'm based in Delhi.
Dr. Akhil.
Akhil, you have muted. You'll have unmute. Yeah.
Can you hear?
Yes.
I am Dr. Akhil Garg from Cancer Hospital, Indore. I am doing my palliative care services at present.
Okay.
Dr. Srikanth.
Devtirtha.
Hello.
Yes, Srikanth.
Hello.
You can
Good
hear
afternoon,
me.
everyone.
Please speak.
Can you hear me?
Yes.
Hello.
We
Can
can
you
hear
hear?
you.
Yes.
I'm happy to present.
our team members, Dr. Chakravarti sir, surgeon, Dr. Surender and Dr. Aarti, who are behind me. Hello. Hello.
Yes. Thank you, Sheila. Dr. Mary?
Hi, I'm Mary Abraham. Can you hear me?
Yes.
Can you hear me? Okay.
Yes.
I have just started palliative care this week only 1 week old. So I'm literally the baby of the team, I think, because I was all the time a neuroanesthetist. And after I did this foundation course, last week only I started working with CAN support in Delhi. I'm based in Delhi. So I'm very eager to know the practical aspects of palliative care.
Welcome. Farzana?
Hi, good afternoon. Good afternoon, sir. I'm Farzana, palliative care physician working with Fasiuddin Khan Research Foundation from Bangladesh. Yes, that's all. Thank you.
Good afternoon.
Good afternoon.
I'm Phunso from Bhutan. I'm the only one. My friend Tara has, yes, she has left for Kanpur for the human value workshop. So I'm the only one from here. Very good afternoon to all, and very good afternoon especially to Dr. Rajagopal. Happy to see you again, sir.
Welcome, Iqbal. Hello, Iqbal.
Yes, hello, good afternoon, everybody. I am Iqbal. We are from Cancer Hospital, Silchar. I have along with me my nursing coordinator, Kamai, hospital administrator, Sarita, and all of our palliative care nurse.
Good afternoon. Welcome. Good afternoon. Dr. Parveen.
Hello. Hello, everybody. Good afternoon. I am Dr. Praveen Sharma from Kangra, Tanda, Dr. Rajendra Prasad Government Medical College. I am the coordinator of the center. And she is Dr. Rekha.
Hi.
She's also working with us, though she is associate professor in Department of Pulmonary Medicine. The nurse I didn't call today, Rajani, otherwise she would be more than happy to join in next session maybe. Thank you, everybody.
Welcome. Migrants. Dilshiba.
Hello everybody, I'm Dilshiba from Migrants, Shillong, Meghalaya. I'm Sandra from Migrants. Ado from Migrants.
Welcome, Dilshiba, Sandra, and you. Glad you are here. Hello, Dr. Sunil. Please introduce yourself.
Sunil, maybe introduce yourself.
Dr. Sunil?
Yes, sorry. I'm Dr. Sunil Anand. I'm the Executive Director of ECHO India. Thank you. What a wonderful sight to see. I counted about 48 to 50 people on the screen. Thank you, Dr. Rajagopal. What a wonderful show. Thank you.
And we have a lot to thank you for. Thank you and your team.
Welcome.
Devinda? Jennifer?
Dave and Jennifer. Dave? Dave, speaker please. Or Jennifer. Here.
मेरे को है ना प्लेट दे देना नहीं तो है ये प्लेट
Yeah, now we can see you, David. Introduce yourself, please.
Dave, Jennifer, please introduce yourself. Internet trouble.
If you wish, you can use the chat option.
I can't hear it. Can you?
Okay, we move on and we come back to the center. Smriti, can you please introduce yourself?
Hi, I'm Smriti, and it's really nice to see so many familiar faces and new faces. So I work with Pallium, and I'm a psychologist, and I also help out with the Children's Palliative Care project. So yeah, nice to meet all of you.
Thank you, Smriti. Nice to see you.
Pallium team. In the next one, please.
The next is showing all our members in the neighboring room, because everyone could not be accommodated in this room. So we can. A little away, they won't be able to speak, but they are all our doctors, Dr. Philip and Vinita. Madam, Dr. Rajagopal's wife, Dr. Chandrika is there, and Dr. Amrita, and Govind is there. So there are several of our team members right there listening to our talk. They couldn't be in this room. Thank you for all of you there. Next one is Dr. Raji. Can you please introduce?
No, not really. I can hear a bit more.
Hi, Raji.
It's because of the network.
Hello.
Yes, Raji, we can hear you.
Just tilt camera, the laptop a little bit. We can't see your face. That's
Is
fine.
it okay?
That's fine.
Nice to see you all, sir. Nandini. And this is my engagement day. I don't know much about Zoom and all, though Nandini had briefed little about what is going to happen. Still, I am sitting here rather uncomfortably at my home, wondering what is going to happen next. I am a palliative care physician currently working with Malappuram Palliative Care Unit, which are mainly community oriented. What else? Yes, definitely associated with Pallium India also. What else, sir? That's all, I think. Bye.
This is exciting.
It says Dinesh Kumar, but Namrata, you don't look like Dinesh. Namrata, can you hear us?
Or is that someone else?
Namrata?
Hi, Dinesh, Namrata, introduce yourself.
Yeah, I'm Dr. Dinesh Kumar.
We can hear you, Dinesh. Please keep speaking.
Okay, I'm Dr. Dinesh Kumar.
Yes.
I'm professor in Department of Community Medicine. We are working with this project for last 5 years, 5 months now.
Namrata?
I'm working here as a palliative care general practitioner. I'm trained in Pallium India for 6 weeks. Working here since 7 months.
Welcome, Dinesh. Welcome, Namrata. Dr. Sangaluna, so happy that you're connected. Your video is not on though.
Sangaluna, can you hear us? Sangaluna?
Dr. Sangaluna.
As Sangaluna is getting ready, shall we try going back to Tirtha and Jennifer, we could not hear your voice earlier.
Hello.
You unmute and talk.
Hello. I'm Dr. Jennifer McCarthy from London, England. I'm working in Kolkata at East India Palliative Care, and this is Deb Tirtha.
And Runa is also there.
Deb Tirtha is a social worker for in East India Palliative Care, and Runa Mitra is here with us as well.
Welcome, Devilta.
Okay. Thank you. Hello.
Sangaluna, we haven't heard from you. Are you able to hear us? Hi. Your video is on. Can you please, Dr. Sangaluna?
Sangaluna, if you can hear us, please introduce yourself.
Okay, we will move on. So we will get into the body of the ego right now, and we are expecting an important guest sometime during our ego program who will declare this our DIPSICO inaugurated. Until then, we will do our discussion. Now on, let us begin with a minute of silence. Okay, so that we get centered into the program and get to begin with a fresh resolution of making this a very successful learning activity. So the silence for 1 minute.
Can I close the door? Maybe that's better for a moment. Hello.
So we are back. Now I give over the mic over to Dr. Vidya, who will give you a brief of what's going to happen today. Vidya, Swami.
Thank you, Dr. Nandini. I have few rules which we have to kindly attend to. One thing is, can you all please mute your mic? I think Debrita and Akil, you both are on. Yes. When you're not speaking, kindly keep it muted and raise your hand when you need to speak. Take turns. Also, I request you all to keep the mobile phones switched off if possible. And if you are expecting an important call, kindly leave the room and talk. And one more thing, regarding the case discussions today, we will be giving special attention to discuss all the relevance and appropriateness of the prescriptions and investigations of all the cases, which will be discussed all the session. Throughout all the sessions, all prescriptions and the investigations will be given more importance. Then anything, if you have any doubt or if you need to discuss something, you can have a private chat with me so that we can address to when necessary. And kindly avoid criticizing or reprimanding anyone who is spoke, even if they are incorrect. Kindly keep it simple. Anything else, ma'am? You just can take over, Dr. Nandini.
I just want to add that, whenever you need to ask something or add, just raise your hands and Vidya will know
yes.
Get back to you. And if you by chance don't get a chance to, speak, then you can send that particular question by chat and Vidya will find a way of getting that answer. So we will begin, Vidya, we will begin with...
Sangaluna is sharing the screen.
Sangaluna, you have pressed share the screen option, I think.
Yes.
We'll just stop sharing, then we can go back to the view.
There is a menu on the top of the screen where you can stop sharing.
If we share, it will change. Just share with me, please. Otherwise, someone call up somebody like we will share. So, on all of you, it is this screen. Are you able to control it? Just try sharing our screen. Dr. Sambaluna? Okay, thank you so much. So now we will begin. So please be mindful of that green button, because when you press that, then your own computer screen gets shared with everybody. So, please be mindful of that share screen option. Okay, now we'll begin with our didactic presentation on the theme topic is treat that pain. So we are trying to talk about the best practices of pain management during our 12 sessions. And today's topic is understanding pain. So the talk will be given by none other than our beloved teacher, Dr. Rajagopal. And we'll be now going on to the share screen mode. So you will get to see the PPTs and you will get to see hear and talk.
So hello again. Am I audible?
Yes, sir.
Yes. Yes, sir. Yes.
Yes, you're audible.
Yes, sir.
Yes.
Hi. Dave and Dave might remember that last year when I was with you all, we spent a morning at Chittaranjan Cancer Institute. We had a teaching assignment to do. They also wanted us to see a few patients, and to club the two, we arranged it in such a way that the patients who were willing were brought into the classroom. One, practically a skeleton of a young woman was carried by her uncle and placed on the sofa in a recumbent position. She, more than a human being, she seemed to be a mass of pain, just pain made visible. The story was that she was not cooperative, she wouldn't take medicines, she wouldn't eat anything, and they put in an nasogastric tube, but she pulled it out. The diagnosis that she was given, or the family was given, that she had gone into depression. Their question was, she has gone into depression. How can we give her antidepressants when she is not teaching anything? I mentioned that story just to make this important point, that we make often assumptions. Here was a young woman, advanced cancer, possibly knew she...
Sorry to interrupt. I think Mayank is not able to hear you properly. Can you get the mic closer or something, sir? Can you adjust the... Sorry to...
Mayank, is this any better?
Mayank, answer please.
Vidya?
Just chat with him, Vidya, and check if he can hear.
Okay, ma'am.
Okay. So, I feel an assumption was made here. Well, you would expect depression in such a person. It was depression. Now, I believe we need to ask people. And very often, if they seem to be very sleepy or something like that, we start talking only to the family and we make assumptions. It's not only enough to ask this person. If they have not had anybody listening to them for the past 2 weeks, really listening, then they don't trust anybody. People in pain, after they have been through half a dozen hospitals, have very little trust in the medical system. So here, I needed to build a relationship. And that relationship cannot be established unless you have some basic human values. If you are pompous and if I act as a big doctor, hey, what's wrong? That it doesn't happen. I owe her the respect that any human being should have to every other human being. And I needed to respect her dignity. These are the essential things. I'm sorry, all fundamentals. I know this is not news to anyone, but I thought, at least me, I keep reminding myself because I have 3 degrees. And sometimes my intrinsic doctor comes into the surface and I forget to give the due respect to someone. So thank you for listening to that lecture. What I did was I sat beside her. I couldn't go to her and say, hey, I care for you. That wouldn't really be great. I showed her that I cared for her. I sat beside her. I think it's very important. I fear, even in this audience, a significant number of people, and I have seen during my visits, significant number of people do not sit beside patients when you take your rounds. I know you are busy. You may have only 30 seconds. But instead of standing for 30 seconds, sit down for 30 seconds. That's what I mean. Talk to them at your level. I think I would sincerely request everyone to start practicing it. Sit down with the patient. And I put my arm around her and said, let us say her, let us imagine that her name is Mridula. I said, Mridula, I see you are suffering. I want to help you. And understandably, I had to have this translated. And I would always instruct my translator, please do not modify my sentence. Translate it as closely as you can. Because very often they think something else should be said and then something else gets done. I asked her, I want to help you. What is your biggest problem? She couldn't speak. I said, I asked, are you in pain? She gave the barest nods because even moving her head obviously was painful. And I said, show me where your pain is. A hand with a massive effort slowly came up and pointed to her tummy. I said, do you have pain anywhere else? The hand moved up a little bit towards the throat. I verified. So you have your pain in the tummy, and I lay my hand on the tummy and she flinched. Even my touch was agonizingly painful. And on your throat, she agreed. And that's what she showed with her hand. But with her whole body and body language was showing me the extreme fatigue. She could hardly move. She was that weak. I want to remind myself here and remind everyone. Sometimes you find pain and your objective is treating that pain. Treat the pain. That's the title. Well, when I treat the pain, my aim is not pain relief, it's improving the quality of life. If I can relieve the pain with a certain dose of morphine, if that's actually making her feel worse, what's the point? So this is something I keep reminding myself, to look at the whole person, not at the nerves, not at the pain. Okay, if I ask you what is pain, you're all going to say some of these things. All the palliative care people will say, pain is what the patient says hurts. Mayank, myself, and a few others being anesthetists may recite the Indian Association of Study of Pain definition. A long definition which starts by saying the sensory and emotional experience. We all understand this. But what do these sentences mean? I mean, in actual practice, what's the Does anybody want to answer that question? I mean, like, what's the relevance of the statement? Pain is what the patient says hurts. To me, it's an instruction to myself that I should start by believing the patient. I'm not claiming that in 100% cases that may be the truth. When none of your staff complains of a belly ache, I know that in a rare situation it's simply because he wants to take his girlfriend to a movie and wants sleep for that day. And it's because these rare events can happen very often, we will not believe the person. Or worse still, we, especially the doctors, because we already know everything. Doctors know everything. And therefore, when I see something that I cannot understand, I don't see why she should be in pain. Then I subconsciously tend to put the blame on the person. She must be having a psychological problem, as if she had, that is her problem and not my problem. There may be an emotional experience. Dr. Troy Cross, in my early days of palliative care, when I said he was teaching me, I was presenting a patient's story, and I said, I'm unable to make out whether this is real pain or psychological issue. And I still remember his face as he put his hand on my shoulder and said, Raj, all pains are real. What a powerful lesson. I mean, even in my mind, though I thought I understood pain, I was making a distinction between real pain and emotional pain. All pains are real. Now, the significance of these statements is that I have to believe her and find out why she is in pain. That's what I did. And then what do? I have to treat the cause if that can be treated. In this case, why was she in pain? Her liver was hugely swollen. And as we all know, the stretching of the liver capsule can cause intense pain. She also had severe thrush. The girl was pulling out her nasogastric tube because the nasogastric tube was not solving any of her problems, it was giving her fever. And she also, 2 days later, acknowledged when she could that her whole body was aching. So these were the things that I had to treat. And not going into the how we treated it today, just making the point that because I spent time trying to find out why she was in pain, these problems could be solved, and because I did not make assumptions, and because I did not go simply by the statements given to me. Now, the other statement was, believe the patient about the pain. But how about the person, especially those with chronic non-cancer pains, who have been living with that pain for a long time, who is eating well, able to even watch a movie, and their pain appears to have disappeared when they are watching their favorite movie, and they are complaining of pain all the time. And when I ask them, how much is your pain? They smile and say, it is 10 out of 10. And people inside are saying, here is a malignant, or she is seeking attention. She would seek attention. Somebody with chronic pain will have attention-seeking behavior. They wouldn't be normal if they did not, because somewhere they are looking for someone who will believe them. And then they will be crying for help to that person. And somewhere they catastrophize symptoms. They make things a bit more dramatic. All these things are things we have to understand that would have happened to us if we had that kind of thing. So, The person who smiles and says 10 out of 10, I would still believe the person. I know that it happens because I have seen this numerous times. So, we start by believing the person, not by disbelieving the person. I will take only a few minutes more. But your usual assessment of pain that, sorry, I may have taught you, or you may have learned from somewhere, is that SPIKE acronym or DOGUS or whatever that is. That is, okay, you see what is worsening the pain, what is relieving the pain, what there's the duration, how long did it last, what's the quality of pain, the PQRST. The PQRST do not include the meaning. I wish T in the English alphabet was followed by M. It's not. To my colleague from long back, who had that back pain, to him his pain and radiculopathy meant paraplegia. To the other person who has a bleeding into his tumor and suddenly the pain is worsening tenfold, to him that pain means death. And when we look at assess pain by PQRST, we forget this fact that they are scales, and that's worsening the pain experienced by your IASP definition. Fear, person's pain. Pain is as bad as imaginable, and then gets worse. This also we need to understand. When you shall give them the 0 to 10 score, 0 means no pain, 10 means, what is 10? Not severe pain, not excruciating pain, 10 is the worst imaginable. So, when you give that score and ask them, how much is your pain? Somebody says 15. Not possible. That doesn't make mathematical sense. But let us listen to the feeling and not to the words. What do they mean? It is so much worse than I could ever imagine it to be. They always remember that story from Bangalore where you use a rupee scale. 1 rupee is the worst pain. 75 paise means 3/4 pain, etc., etc. So the carer explained all that. So if 1 rupee is the worst imaginable pain, how much is your pain? He brought out all the money from his pocket, laid it on the table, it's as much as this. And we need to understand that our scoring system is faulty, not his statement. Our scoring system is inadequate to convey the meaning of the pain. So this is something I keep reminding myself. A scoring system, any scoring system, is not cast in stone. The system has to be flexible for us to understand this point. And I would recommend that when you are all teachers in palliative care, and when you teach pain assessment, always teach them to look for the meaning of pain for the person. So when you felt that, what was the thought going through your mind? That question needs to be asked. And my final point, I see that I have only a couple of minutes. You all know this. You all know about sensitization and recruitment. You all know that when pain exists for a long time, in that picture, where I have written peripheral nerve, we have the nociceptors. The red flare is over the dorsal horn of the spinal cord. And when pain impulses keep getting transmitted, reach the dorsal horn of the spinal cord, gradually the whole nervous system gets sensitized, but particularly the dorsal horn cell. The implication, just to remind you, if X number of impulses, electrical impulses, are traveling from the peripheral nerve to the dorsal horn cell. And X number get transmitted to the brain today. If the pain is untreated, by tomorrow, for every X impulses traveling from here, 10 X impulses will be going to the brain and it will keep increasing. The girl Mradula, whom I treated in Kolkata, possibly had this. In addition to the sensitization, the whole body gets recruited. The extent of area of pain keeps on increasing. That's also an expected phenomenon. So, this all of you know. And how do we treat it? What I taught you, or what immediately strikes your mind, must be a NMDA blocker, like ketamine. But wait a minute. If by any means you can block the pain successfully for a period length of time, all the anesthetists, hey, we can do it. Maybe you can. If we are successfully blocking the nerve peripherally or centrally, there is a good chance that we can stop this process, prevent its progression, and in a few days, the pain may gradually come down. This is called breaking the pain cycle. But it may not always work. If the whole nervous system, central sensitive system, central nervous system has been sensitized and may have over time even become anatomically abnormal. So that spontaneous impulses will keep flaring from the dorsal horn or the central nervous system. Even if the peripheral input has stopped, then this may not work. But if it has, the sensitization has not lasted too long, this may be one way of treating it. So that's how Mayan's epidural analgesia only with local anesthesia seems to reduce the sensitization and recruitment, or some other medicine manages it. But if that cannot easily be treated, we may have to resort to NMDA blockers like ketamine. I mean, the reason for my bringing that up was just to highlight that ketamine administration is not a foolproof method of treating central sensitization, and it may not even be essential for treating central sensitization, especially nowadays. Ketamine has been scheduled in Schedule X and its availability is slightly restricted. So important points about believing the person, not making assumptions, asking the person what's wrong, always asking why somebody is in that kind of pain, not the first point, treating the pain is not the objective, improving the quality of pain. And finally, about central sensitization as a real entity to be treated by early intervention and by breaking the pain cycle or with ketamine. With your permission, Vidya, shall I stop there?
Yes, sir, we'll open the floor for discussion. And so if anyone wants to ask questions or any doubts, they can ask.
You mean the hand has to go up, right?
Yes, sir. Yes. Hand has to go up and we'll. Dr. Nandini, please. Yeah.
I want to ask whether the lecture was audible to everyone. If it was audible, please raise your hands, and if it was, continuously audible, please raise hands so that we know how it went. Okay, thank you so much. Please feel free to ask some questions. We have another 10 minutes. Vidya, how much time are you giving for discussion?
15 minutes, ma'am. 15 minutes.
Okay.
So no hand raising, sir. Maybe you can add some more points if you want to, sir.
No, I mean, but the experience tells me that if you wait for another 30 seconds, hands will there. Yes. Iqbal.
Thank you very much, sir, for sharing your story, sir. That was really a touching story, sir. Also, we have experienced such an experience. We always feel sometimes that many of the patients, they are put Ryle's tube, they don't want. In the dead of the night, sister comes and complain us that the patient has removed the Ryle's tube. Then in the next morning, we scream on the patient, why you have put out the Ryle's tube, without knowing the reasons behind it. But after hearing your lecture, sir, it makes sense that we should always undermine the reason behind what the patient does, sir. Ultimately, we should find out the cause of what is the cause that the patient has removed the Ryle's tube. It may be depression, it may be pain, it may be somatoform problem. So I really appreciate what you say, sir. It's really appreciated, sir.
Yeah, please talk, sir.
I just speak on, Vidya?
Yes, sir.
Thank you, Iqbal. Just to add that the usual way of handling that situation is to restrain the person by tying the hands and leg feet up. That may throw it. Sorry, did Mary's hand go?
Thank you very much for this. What I like most importantly was you always stress on that when I was there, sit by the side of the patient. That is something that I also find we are lacking, and there may be some unique conditions sometimes. I was thinking of one of my patients. She was having severe pain in chest because she was suspected of having tuberculosis. Nobody was able to give, even to listen to her. And yes, on X-ray there was a cavity that further increased the chances of tuberculosis, but nobody bothered about her pain. And the pain was so severe, she was one of my few patients whom I administered 30 milligram morphine for hourly. Yeah, she died after some time. Dr. Rekha diagnosed her later on with squamous cell carcinoma. But when we say sitting by the side of the patient, this is really important. Then only I feel, like you said rightly, there is a relationship that develops. And this, I have beautiful photographs. This I really ensure that I do. Even if I don't talk, I will go and simply sit by the side of the patient with a hand on shoulder. Sometimes, yes, I do remember what you taught me. We have to be socially correct also. But this really helps. Thank you very much, sir.
Dr. Ms. Punsha from Bhutan, yeah, you can talk.
Thank you, Dr. Vidya. Thank you, sir. Sir, thank you again for another inspiring lecture, sir. Sir, I would like to know a little bit on the words that you just said, sir. Look for the meaning of pain. Look for the meaning of pain, sir. How, I mean, could you throw some more light on that, sir? Thank you.
Sir, talking. Yes, sir. You have done it.
Yeah, no. Sorry. Okay. When I am with a person and the person is saying this pain is so severe, etc., and they say, so when you had that pain, what did it make you feel? Did it make you scared? Now, okay, you say you have this severe pain. I mean, what thought goes with the pain? Are you afraid of pain? And then usually they bring out, I thought I was dying, etc. Sometimes I want to know not only the the nature of the pain, but what that pain does to you as a human being. Can you translate that to your own language? What does it do to you as a person? How does it affect your life? Does it affect your relationship with the family? Specifically, does it affect the relationship with your spouse? A good number of times, the person cries at that time because this is something that they never get a chance to explain to somebody else. They are complaining of pain that makes them irritable, and the spouse responds in anger. So these are a few questions I would ask.
Yes, Smriti, you can talk. You have to unmute, Smriti.
Okay, can you hear me?
Yes, yeah.
All right. So just I have more of a comment than a question, and I feel that one of the things that we need to come to terms with is our own discomfort as clinicians with intangible sort of things. You know, like we're always we have we were talking about physical pain, Dr. Rajagopal, but mental side of things, one of your earlier slides, you talked about how, you know, they said she's got depression, and that is an assumption. And very often I find these mental health terms being thrown about without adequately exploring what it is. With our own difference
Your audio is breaking up.
Because of our own discomfort as clinicians, we tend to sweep a lot of things under the rug, or we want to put it in a vague sort of box that is easier for us to digest. And I think the questions you just, some of the sentences you just said, or the questions you should ask, which will lead to that sort of like a breakpoint discussion, those are very important. And just as we upgrade our skills in, say, as I'm not a medical doctor, so, but I'm assuming just as you need to upgrade your skills, we need to upgrade our skills in determining, these factors as well. One book I will recommend right now, one area I will recommend right now to explore is dignity therapy. There are some wonderful, there's a lot of guidance in that, in that approach, which as people who are working with the kind of patient demographic we see, will be helpful. There are some very insight, a lot of some right.
Smriti, part of your talk was not fully heard. I think the bandwidth was on the lower side. So probably those who are experiencing a lower bandwidth can switch off the video camera so that we can all hear the voice. So we actually missed part of your talk, your comment.
Okay.
It will be good if you switch off the camera and speak for a minute more.
All right. So,
one thing that we did here was that we were recommending dignity therapy in Georgianos. That possible?
Yes.
Okay. Thank you.
And if I may add something to the list of questions, sometimes we may even have to bring up, did that make you think that you were dying? Because death is a word that sometimes they don't want to speak about. But sometimes when you give the opportunity, they actually get to live. Yes, that's what I was afraid of. Are you still afraid of that? What do you think is happening? That also opens the door to going deep into very important things. Did Raji's hand go?
Raji, did you have a comment?
So could you just elaborate, because in between my audio also was getting broken in between. So could you just repeat the last few lines?
What I just said just now?
Yes. Yeah.
Like,
in between.
When they still look as if they are afraid, sometimes they said, we may have to bring up the word death. I would ask them, did that make you afraid that you may be dying? And then they would say, yes. And are you still afraid of that? Most people do not want to bring up the word death. And sometimes you feel they are ready to talk about it, and we may have to start the meaning of faith, mainly death. And you can start with the past tense, that makes it safer. At that time, did you feel you were dying? And if they agree, does that fear still linger? And that opens the door to a discussion about their fear and their suffering.
Yes, if a chance comes, am I audible?
Yes.
If I get a chance to explore similar kind of concerns from the patient, I prefer to do so, because many patients carry this kind of fear. I mean, fear is a simple term, and later it may transform to anxiety, which will add on to the symptom, whichever symptom they are having, whether it is pain or some other kind of symptom. So if at all I get time, I used to explore these concerns, and definitely many patients are comfortable to have a discussion. Only very few patients are reluctant to open up. The thing is that many times we professionals, we fail to ask. We assume that, as you told, as you have cited in the very beginning of our discussion, we are a bit reluctant to open up or bring that word death in our conversation, because it's a taboo subject. So that is a fact. Patient is not reluctant. Probably the family members, but not the patient. Thank you, sir.
And may I, Vidya? One very important point, that we are reluctant to bring up and do not give the patients chance, especially in chronic pain, persistent pain, is bringing up issues related to sexuality. We are all uncomfortable talking about sexuality. We think we know everything, but we are scared still to bring it up. And sometimes, if you simply ask, what does it do to your relationship between you and your husband or with your wife? That's appropriate. And that opens up. They very often get very much relieved and brings out a lot of things which you would have never known, but which may be very easy to solve by just an open discussion with a couple.
So, I think Debrita and Mary raised hands.
Can we move on to case discussion, ma'am, because we are running out of time as well.
That's fine. That's fine. We can ask the question later.
Please type your questions, and we are going to have some time at the end. We will take them again, right?
Can you just send the question to the chat section, Deborah, so that we'll bring it up there later when we have time. Okay? Is that okay?
Okay.
Yeah,
Yes, sir.
thank you.
Yes.
So, so the volume actually towards the end, it was breaking up, sir, your voice. I don't know why, but towards the end, it was breaking up from Trivandrum side, sir. And so we will move on to the case discussion. If yes, can you raise the hand? So yeah. Okay. Yes. Dr. Iqbal. Dr. Iqbal.
Hello.
Yeah, you will be first to go with the case discussion.
Okay, madam.
I will share the screen.
Okay.
Is it okay?
Okay, madam.
Okay. Can you see the screen?
Yeah. So once again, good afternoon, everybody. I would like to share the history of a patient. The name of the patient is Mr. Nurul. He's a 22-year-old guy coming about 45 kilometers away from Silchar, that is from Hailakandi district. He has passed HSLC and he is a businessman by occupation and he earns about 4,000 rupees per month. So this patient came with a diagnosis of squamous cell carcinoma of the left auditory canal, and it was a very much advanced disease invading the base of the skull as well as destroying the whole mastoid. So this patient was referred to our hospital for radiation. And when he came, he was having severe pain, very peculiar kind of pain, severe pain 10 by 10 along the distribution of the trigeminal nerve that is in the left temporal area to the entry to the preauricular area, and it was tingling, burning in nature, and he had also left facial palsy. And the first thing, and he was also having lot of vomiting, and we have started some drugs for controlling his pain, because he was not started initially radiation. He was referred to the palliative care department for controlling the pain. As you can see the history, I'm not going to repeat it again. And we gave morphine and titrated to about 40 milligram Q4H, paracetamol 1 gram 6 hourly, pregabalin 75 milligram twice a day, and gabapentin 300 milligram thrice a day, haloperidol 2.5 milligram BD, sucralfate, ranitidine, ondansetron, and also metoclopramide, number of antiemetics for controlling his nausea and as well as vomiting. And one more important thing is that whenever he sits, the pain used to come in severe intensity. Initially, he used to sit for about 10 minutes while he used to talk with me. But after 10 minutes, he would say that I want to go to the bed because the pain is increasing. So once he lie down, the pain decreases. So this is about his physical history. So we also took the social history in brief. He's the eldest son of the family. His father expired few years back, and she stays along with his mother, who is a homemaker, 3 younger brothers, 21, 16, 17, and 3 younger sister, 18, 17, 12, and 8 years. All of them are studying except the elder brother, who dropped out of school because he was taking care of him. Now, it's not visible. The history is not visible.
Part of the history, Bal.
Yeah. So you're just finishing the history. Please move up, please. Yeah.
Move up.
Yeah. So we also took a religious history according to the protocol you have supplied. We took a religious history He has a firm belief in Almighty. According to him, Almighty will cure his disease if he is willing. And also another peculiar thing, we went on digging him, and he could tell us that he has a girlfriend, whom he believes very much, and they love each other. His girlfriend is still studying in HS, and even she's also praying hard. When he was narrating this story, he just wept a lot, and he told me that even his girlfriend is praying for him, and she's even willing to sacrifice her love at the cost of his recovery. So, but he has a very good social support. Friends comes to visit him once a while. So we did also read symptom review. Pain, as I told you, now the pain has reduced little bit. It is 5 out of 10 after the medication we have started. Also, he is receiving radiation therapy. He has completed, I think, about 5 to 6 radiotherapy, 11 radiation therapy he has completed. He is not dyspneic, he is not constipated, he is not delirious, he is not depressed, not drowsy, but he is anorexic, and he has an element of anxiety. He has moderate anxiety. Vital parameters are within normal limit. All the lab tests are within normal limits. I would like to just share the present CT, which shows that it has a large heterogeneous mass in the left mastoid region with vascular involvement and bone destruction up to the petrous apex. There is also erosion of the C1, C2 vertebra, and his PPS score is about 60%. He has an individual decision-making capacity, and we have identified his younger brother as his surrogate decision maker. And we have patient has a definite goals of care. We have found that he is very much aware of the diagnosis. Our psychosocial psycho-oncologist is there with us, MS Kreshap. He is very much aware of the diagnosis of the cancer and prognosis, but he don't know how long he will live. When I ask him how long, it is not clear to him. He wants cure if possible and prolong his life so that he is able to fulfill his duties as a brother towards the family. So he has some unfinished business towards his family. He wants to get rid of his pain, nausea, and anorexia. He wants to go home and take radiation from the OPD. And he wants to go home because of the food is not good here. He wants to have good taste of the food at home. And another information, patient had asked me if he is willing to know about his life expectancy. I asked him whether he is willing to know about his life expectancy, but I don't get much interest from him, so I just avoid that topic. This much about the history. Thank you very much. Now my question is that the main question is that, sir, it is a very complex kind of pain what we felt over the last 4 and 5 days, practicing a lot of drugs, but we are not unable to achieve the complete pain relief, number one. So how to achieve complete pain relief in this patient? Number two is that he is very young. She has so much of psychosocial issues. Now, when to tell the diagnosis to the patient? We are not able to develop much courage because he's very young. When to tell the diagnosis and how? And number three, how to get rid of the nausea. He's not still having nausea. Thank you, sir.
Vidya,
Yes, sir.
Vidya, how many minutes do we have to discuss this one particular patient story?
Sir, each case I've given 20 minutes to go, sir.
So we
have another 10 more minutes
10 more
for
minutes.
discussion.
Okay.
Yeah.
Before I go, I ask for comments for the various questions. For our future discussions, do not give the patient's name. We protect the patient's identity. This is something that gets transmitted across the world, and we will hereafter not mention patient identifiers. So, many of you heard the, shall I reserve the last 3 minutes for a few comments, and in the meantime, shall I ask for questions or comments from the audience?
Yeah, Dr. Parveen, please go ahead.
Sir, in this case, I was thinking of like the giving pregabalin and gabapentin both. Do they have some additive or synergistic effect?
So, Iqbal, before we answer Parveen's question, you mentioned that the pain was in the trigeminal nerve distribution. But the way you described it was not in that distribution. You said it was over the temple and over the ear. Or was it through that half of the face? Because if it was only this, maybe there might be a neuropathic element. You also described infiltration of the petrous bone and also the cervical spine, which I am assuming is malignant infiltration. And are we looking at a predominant body pain with a maybe a minor neuropathic component? I'm not sure. Iqbal, would you have a comment about the distribution? Is it over the one hemi-face, or is it specifically this area?
No, the typical complaints were something like that. The pain was in the left hemicranium, not total hemicranium, sir. The pain was in the temporal distribution, sir. It is in this region, and it is coming up to here, and also it is going to the preauricular region, but not typically coming to the distribution like this, not coming to this mandibulary, maxillary as well as mandibular division, not ophthalmic, sir. It is typically here confined to this region, sir.
Okay, so that is not a typical trigeminal nerve distribution, in which case it could be from here over one half of the face. Maybe there is an element of involvement of the nerves, and that brings us to Parveen's question. The combination of gabapentin and pregabalin. Would anybody else have comments about that? Would you like to?
This is Ann Broderick. We typically use gabapentin first in our context because it's less expensive, and then try pregabalin. But I wouldn't typically have both of them at the same time because of the potential for side effects. It's hard to see what side effects it might be causing, but I would usually use those in succession, not both at the same time. The history went too fast for me. I wasn't sure if they were both being used at the same time.
It has been used both at the same time, ma'am. A patient is on pre-GABA 75 BD dose and I think gabapentin TDS dose.
They are very similar drugs with the same mechanism of action. So, the more rational thing will be to start one and build its dose up rather than this combination of both. This polypharmacy to me seems unacceptable. So the dose of gabapentin could go up a lot unless side effects occur. That's one thing. I would also have a question about the nausea. Did he have giddiness? Did he have vertigo? With the repeated involvement? And if he had giddiness, was the nausea associated with that giddiness? That's a question to ask. Yes,
most of the time. He has nausea most of the time, sir.
Okay. I mean, going back to the history, you remember the person is on any corticosteroid? The medicines?
No, sir. He was not on steroids.
The person is getting injectable diclofenac 3 times a day.
Yes, sir.
Why injectable Iqbal? Because that's quite a painful injection, deep intramuscular. Would oral be more acceptable?
Yes, sir. So we gave, sir, diclofenac, sir, initially, sir, oral tablet, sir, to follow the WHO and analgesic letter. But the oral diclofenac was not giving any pain relief. So in the evening, I came and for the round, I saw that the patient was severe pain. So I thought that let me try with a quick IM injection of diclofenac. But after the diclofenac injection, he told me that it was the only drug which gave him the most good pain relief, sir. So, because since I wanted to control the pain immediately, because lot of pain was there, sir. So I started giving diclofenac. I am at least 2 or 3 days as a trial, sir.
And it is understandable that diclofenac injection will give better pain relief. Orally, you are giving 50, by injection, usually you give 75. And by metabolism, the effect can be twice as much. But you will also remember that the toxicity, except for gastrotoxicity, might also be higher. I'm quite agreeing that that may be giving relief. And if that is what is giving the relief, maybe that's what it should be done. I have 2 questions to the group to answer. Would you send this person immediately for palliative radiotherapy? 1. 2. Would you consider dexamethasone? If so, what for? First, radiotherapy. Group's opinion.
Those in favor, raise hands.
Those against, raise hands. Personally, I don't know if it can be done. Possibly it can be, but whenever
The patient is already on chemo and radiation, so palliative radiation, and he's on.
because I thought the person wanted to go back for radiation in the notes. No.
No, sir. I think he is on chemo and radiation. Is that so, Iqbal? Can you clarify?
The patient is getting concurrent chemo radiation. He gets
radiation.
Yeah, once a week chemotherapy, and he is getting radiation therapy, palliative radiation therapy.
So, oh, thank God. I mean, we can expect that in about a week or so, he may get significant pain relief, because with radiation, it does take 1 to 2 weeks for optimal action. Because with the bony infiltration, the localized pain, I would consider that the most promising means of pain relief. How about dexamethasone? Somebody please comment about whether.
Yes, I would.
Yeah, Parveen, you can.
Sir, I think in this case, dexamethasone would be of use because yes, if some edema element, if it is reduced, this would have even neuropathic pain as well as bony pain if it has infiltrated to that area.
And also remember that the steroids have a broad spectrum anti-emetic effect. The anti-inflammatory effect directly or indirectly may help with the nausea also. But also remember that in somebody getting 75 milligrams of diclofenac 3 times a day, naturally he's already on gastroprotectants. So that is something to be considered. I think Vidya is likely to shut me up about this case in a minute. So I also wanted to bring that up. I thought Iqbal said this man if his prognosis has not been discussed, including fear about death, things like that, many other symptoms may be hard to control. Here is a man in love with his girlfriend, wanting to look forward to a marriage life, etc. Very unlikely for all that to happen, but still those feelings need to be brought out. Would he be able to share it with his girlfriend? No, usually not. With his parents? Usually not. You may be the only person who might lend a ear to those fears, and by discussing that, he may have the chance of coming to terms with the situation. And then they may decide whether to get married for the last few days or whether not and just be supportive. I think that would be a crucial, vital question to ask.
Sir, I have a question. Can we use antihistaminic and antimuscarinic agents since the eighth nerve side is blocked? It will be involved in the external auditory canal. Can we, sir? Promethazine, maybe?
And do you have an answer to that?
That wasn't what I was going to think about, so.
Vidya, that was the reason why I particularly asked whether the nausea was related to giddiness. Because if it is, certainly that would be one thing that I will consider, one of those medicines. It could well be Iqbal. If you go back to him and ask, he has middle involvement. Is giddiness causing nausea every time? And maybe then that may be an added solution. And then again, who knows, dexamethasone may help.
I wanted to comment about the history that you gave, which is that his pain was very intense when he was sitting down and better when he lay down, does suggest that there might be some invasion of the inner ear into the otoliths of the inner ear in the labyrinthine canal. And I think that historical feature was very important that you got that. That would steer me closer and more quickly towards steroids because I believe that the inner ear has been affected. I think it would also be helpful, or at least I find it helpful, to explain to patients the mechanism of why their pain might be different in one position than another. The more patients understand, the more they can report back to you when you want information. So very helpful to hear that. I would tend to use dexamethasone because of its protein, its large effects on both nausea and the potential for decreasing inflammation during chemoradiation. Whenever I start whenever I start dexamethasone, I speak to the radiation doctors and the oncologist to make sure that it doesn't have any interactions and that they're aware that I'm depressing immunity with the steroids. But I think that's a very interesting history that you gave, that it's better when it lies down. Good history taking.
Can we move on to the next case, sir? We will keep the discussion till the, maybe if we have some time, maybe we can do it later. Is that okay?
So should we summarize it? Right?
Iqbal?
Shall we summarize the points together?
Points discussed? Yes. Iqbal, do you have any specific question you want to ask, or shall we summarize the case and close it?
It's okay. It's very clear now. Thing is that we should we use dexamethasone in this patient. I thought because the patient was already getting dexamethasone because he is along with the protocol of chemotherapy. So I did not start, but definitely regular dexamethasone would have helped this patient. And when to break the bad news to this patient, this is a concern to me. Whether to wait for some time, or I'm not very much clear what is life expectancy of this patient. These two things. When you will come next time, I have to answer this question in mind. I have to keep in mind. So how to deal with these two issues?
It is prognosis you are talking about, Iqbal, right?
Yeah, prognosis. How long you will live with after completion of radiotherapy, and should I break the diagnosis now?
Okay.
That is, he is going to die very soon.
Okay. We will come back to this. Sorry. Yes, sir.
But we do not have to give an answer to that a straight answer to that life expectancy question, because you don't know. And not knowing that is not a reason for not exploring. If we straight ask you, how long have I got Dr. Iqbal? You might say, I honestly do not know. Let us hope that will be a long time ahead. But perhaps it also helps to prepare for the worst. Let us hope that you will survive for a long time, but let us help you to make some plans for the time you have, irrespective of the length. Are there things that you desperately need to do? Why not do it anyway? And hope that you have a long time to live. That would be my approach. But I would still give him the opportunity to bring out his tears.
Dr. Sangulana, you're sharing the screen again. Could you please switch off the sharing screen?
Dr. Sangulana. Okay, well, till then I'll summarize what we discussed, ma'am. With Iqbal's case, I think the recommendations we got till now is not to use both pregabalin and gabalin at the same time, gabapentin at the same time, since there's an increase in side effect. And dexamethasone will be recommended in this patient because it has an antiemetic property, as well as it helps with reduce in edema as well. Regarding prognosis, Iqbal, if we have more time, we will come to it again towards the end. Is it okay, sir? Anything else?
Yeah. I think in the recommendations, there is also exploration of psychosocial factors, especially because there is a belief that, with adequate prayers, he's going to get relief. There may be a lot of hope, which is, pressurizing him to get better. So as Dr. Rajagopal suggested, we should explore with him his actual feeling, which he has not been able to express at all. And also we suggested that the non-steroidal anti-inflammatory drug that is going on, can we try the same dose orally instead of injection, which are being given at 3 times. Although we should just check it out whether oral tablets can manage the pain.
Not the same dose.
Higher.
No, lower dose. I mean, as injectable diclofenac, you usually give up to 75 because we believe the gastrotoxicity is less. Orally, you never go beyond 50 as a single dose. So it will be less effective. But with steroid, maybe that will become acceptable.
And we also talked about checking if the dizziness and nausea are interrelated. And if they are, then a choice of antiemetic would be antihistaminic, antimuscarinic kind of drug. So, and we also said that we are not going to use names by discussing the patients. And the important message from here is to look at the medicines and see what are really required for this patient, and only choose those medicines and not to repeat the same group of medicine, 2 different drugs together. So here we are having multiple antiemetics, there are multiple anticonvulsant group of drugs. So that has to be looked into, polypharmacy. So we will probably summarize our recommendations in the document again and send it to you so that it gets sort of this discussion is documented and sent back to you. And if you have more points to discuss on this during the last bit of time in our next eco session, we can bring up the same patient and see how it has helped. Okay, but Vidya, now I think you'll really kill me if I take 1 second more. On to the next.
Thank you, Iqbal. And I think we'll move on to Bilsheba's case, I think. Yeah. Second will be Bilsheba. Bilsheba, are you ready?
Yes.
Shiva? Yeah.
Ready.
Share the screen. Can you see?
But it's not a home page.
Yes, ma'am.
Yes, that's right.
Okay. Yes, we had one patient last year. He was 42 years old male, and he was presented to us with the cancer base of tongue. And this patient we met, he was referred from oncology department to the pain and palliative care on the 28th of June 2016. On first assessment, the patient's condition was fair and the pain scale was 8/10. He was already on morphine 30 mg every 6 hourly from Mizoram. And he got from Mizoram hospital somewhere, but he was on irregular. He took the medicine on irregular basis, and because of maybe he was not aware that he should take the morphine as told to him, he stopped taking morphine, and then he came to us with this pain that is it was 8/10. And then when the pain reoccurred, we started the morphine tablet as advised by the pain and palliative care physician, 20 mg every 4 hourly. And then after we assessed him, it was found that his pain scale was 4/10. That means the pain was controlled. And then the growth from the base of the tongue was protruded again, and he was planned for palliative chemotherapy. The patient was responded to first and second chemotherapy, but but the third cycle was not responding well, and the tumor started growing again. So patient became very weak, and the oncologist explained the prognosis, but the family members insisted to continue the treatment. Then the palliative care team visited him at home, and he was always under our care, and on further follow-up, the pain scale was 10/10. Then the doctors advised him morphine tablet to 40 mg every 4 hourly. We saw that the disease was progressing. Then the general condition of the patient also was down, and he had this periorbital edema on both eyes, and the growth of the tumor has protruded outside the mouth. He was already on NG tube, feeding, and tracheostomy tube. And the patient communicated with us by non-verbal means, and he was on morphine 40 mg every 4 hourly, and Wisloan 10 mg once a day, and with syrup use 2 teaspoons daily. Actually, our main concern was to improve his quality, the quality of life. But when we counseled the family members, they were not ready to accept the fact that the patient was not going to make it. And this led to avoidance of contact with the palliative care team. And in spite of all these, the patient accepted his problem, but unfortunately the patient passed away in the month of November 2016. So our problem here is that we would like to get from the opinion from your side that when after we have given this the counseling to the patient accepted, but his relatives they did not accept at all, and at last they avoid us, and we learn after we contact them later that they told us that patient passed away. So we would like to learn from you, because with us on regular basis we don't have the doctors to go along with us, only our medical social worker, and we the nurses had to face this problem. From your side, please help us what to do whenever we face this kind of situation. Thank you.
Thank you.
Shiva, thank you very much. Vital question. Shall we first ask any members of the group who have not spoken the last time or so far to give their comments? And people who are quiet often have much to say but do not get the chance because some of us talk too much.
Vidya, can you stop sharing? We are not able to see the.
Yeah. Sorry,
So,
I'm
people
not.
who did not speak so far.
Yeah.
Prasanna? Any comments?
I'll comment on the first one afterwards, sir.
Okay.
On this. Thank you.
Srigan? Jennifer?
She left for the clinic. She left for the clinic.
You
She will
Dave?
join afterwards.
How about you, Dave?
It's okay. No question. No question, sir.
Akhil? Akhil, any comments?
Dr. Dar?
Mary? Oh, Akhil is going to
Smriti raised the hand. Shall we ask Smriti to talk?
Smriti?
I noticed, I mean, of course, thank you for sharing that. And one of the problems, obviously, that has emerged is, avoidance with the palliative care team because they were not willing to accept what was being said. But in the case notes, one of the things I noticed was in psychosocial assessment, there was one sentence only, and it said mental health stable. And that was all there was in the psychosocial assessment. Now, I think in this particular case, or in cases similar to this, the psychosocial assessment becomes that much more important because I sense from the team that one of the things that has disturbed you is the fact that you weren't able to communicate effectively to the patient, and that shared decision making was not exactly a cohesive sort of exercise. In such a case, if we take a step back from the physical and see what's going on a psychosocial level, to say the mental health is stable, I don't really know what that means. On what parameters were explored in order to determine that? That's just a question I want to ask you because I feel like a further exploration of a psychosocial dynamic maybe might give us more insight into how we could have better helped this patient. So on what parameters was that determined that his mental health was stable, and he had I can't remember the exact words, but he had a good relationship with the rest or something of that sort was what the case study said.
I would like to add one more thing again. After meeting this patient, we used to communicate with him by nonverbal communication, mostly by writing. He responds to us by writing, and then he does not show any kind of depression or any kind of any negative feeling from him. And from his side, we got the positive remark. I mean, from the related point of view, it seems that they don't want us to get involved with them anymore. So that is the reason we lost communication with him for some times. When he passed away, we did not know. After we contacted him, then we realized that he passed away.
So it sounds as though, sorry. It sounds, okay. So it sounds as though the family was being protective of him. And I mean, that's where it seems to have come from. And in such a case, I would like to just say that the psychosocial assessment should not only be directed at the patient who is being treated, but since we are looking after the family as a unit of care, sometimes the dynamics give us more insight into what's happening rather than just a one-on-one conversation with just one person. We never get the full picture if we speak to just the patient or just one person in the family. I think in order to piece together, I know very often there's a time constraint, so this is not always possible. What I'm describing is an ideal situation, but still there are ways in which this can be done, and time management can be utilized in order to, like a jigsaw puzzle, piece it all together. So then somewhere in that discussion, we might be given some leeway, and we might figure out a way to help the family as a unit, not just direct our attention at one person only. So that's something that I think is important.
I think also, Smriti, maybe psychosocial assessment for all the caring departments and the oncologists and palliative care physicians will obviously deeply distressed by this person. Right? And this is fairly typical. Is it true that you were trying to convey things about the prognosis which were possibly in conflict with what the oncologists were trying to tell you? Is it possible that the oncologist said, let us try? I mean, most doctors are reluctant to talk about death or failure of treatment. They want to keep up the morale, maybe good news, and they may say, let us try, let's hope for the best, etc. So you have no chance, I would say, of achieving success in good communication if contradictory opinions are being given by the treating doctor. They are the specialists, messengers of God who can save their child, and you are giving bad news. And naturally they will want to take their point of view. So unless we are able to come to a common agreement with the oncologist, and till we speak the same language and convey the same message, maybe it would be better not to try to speak to the person and confuse the family. And parents being protective of children, they're inflicting a lot of suffering. It's very painful but very common. And this happens all the time, and the child gets very angry and doesn't speak to the parents anymore, and they have to live with the grief for a long time. But except for our communication within our medical community, we don't find any easy solution.
Dr. Parveen wants to say something, sir. You want to talk? Parveen?
Thank you, ma'am. Sir has already said what I wanted to say. We get actually in our area, we get quite a few such cases. Like they either close or somebody has many advisors. They don't want to accept this because, like sir said, there are many advisors who keep telling them that no, this study is there, this would be beneficial, this would be. So what I have found out to be useful is I just try to be with them. I don't advise them much about treatment. I don't advise them, I don't counsel them much about the future prospect. I just be there in a hope that maybe they would need us someday. That I find is, and yes, that is always there. After some time, they need us. That is what I found out.
Praveen, that's very insightful. And personally, I also run into trouble. Looking at it only from the child's point of view and trying to protect the child, and I antagonize the family. And I mean, it's sad, but we have to come to terms of acceptance that there are situations where needless suffering is inflicted on its child. And I think Praveen's advice was very good. And continue to be there. Offer the advice when they want us. And someday, when they are desperate, they need your help. And we have to accept partial failure at times.
I would like to add one thing that to Vishima. If we can maintain our relationship with the patient and family, that would be a great, important objective for us as a team. So the fact that this patient is young, around 42 years, right? And I think when you spoke, it was to the patient, and what I understand is the family was not ready for it, and the oncology teams were already giving their palliative chemotherapy. So probably our focus should be more on maintaining our interaction with the patient in terms of taking care of the symptoms, communication, etc. And the timing of discussing end-of-life care and prognosis has to evolve after a stage of rapport building, the trust, and the confidence with the team. Are you able to hear us, Vishima? Okay. So in this particular patient, since there was intermittent relationship with palliative care and the more continuous relationship was with the oncology team, probably we need to assess whether are we ready in our relationship with the patient and family to bring up prognosis and end-of-life care discussion. That would be something we need to look at also. Vidya, is there anyone else? Because I can see Dr. Clara is online, so we will, at the end of the discussion, we will invite her. So Vidya Vishwanath has something to say. Vidya, unmute yourself, Vidya.
Hello. This is very interesting because I work in an integrated setup.
Vidya,
I work in an
come closer.
I work in an integrated setup. So many a times patients see me first. After that, once they go to oncology, then they just don't want to see me for a while. And then towards end of life, they come back again. That's one aspect. Another aspect is exactly what just happened, because there's such a wide chasm between what they've been told and what we are trying to tell them. So here I always feel is whenever they come back to us, greet them as warmly as we can. And sometimes, kind of keep the prognosis a little away and focus mainly on the physical aspect. So once they develop that trust that this person can help control our pain, this person will always be there for us, they kind of come to us. And then slowly, one by one, the family trickles in. So maybe we lose out on really explaining prognosis, talking to the family, gaining everybody, but it benefits the patient because the priority has to be, is he comfortable? So if we put that before the fact that, are they accepting me? I think it works in our setup. Though in the West, it may be like you need everything at the same time. But if we prioritize patient comfort and give that to them, it becomes the basis of trust. I mean, this is whatever little I feel.
Thank you, Vidya. Ma'am, do you want to introduce Clara and come back to the discussion, and what's the plan?
If this case discussion is over, then I think so.
You have to summarize because I was not able to concentrate on the whole thing.
Okay, so I think in summary, what we have understood is that Shiva's team had a difficulty with maintaining the relationship with the patient and family in such a way that they were extremely distressed at the end of life care discussion did not get followed up, and the family avoided the team after that. So the recommendations that came up was the importance of cohesive understanding of the patient, the oncology team, as well as the palliative care team as to what is the goal of care. If the oncology team communicates a different goal of care and they have the primary involvement in the day-to-day management of the patient's concerns, then the palliative care team, as very beautifully put by Dr. Vidya Vishwanath, would be to be there, be available for all the intermittent concerns that they come back with, so that they build up the trust with us. And if and when the appropriate rapport and the timing comes up, and the question can be raised, you can bring it up. An important component in this particular case has also been the family, which has been very protective. And although the patient you have mentioned has accepted the situation, the family avoided. So here, the palliative care is almost like working versus family versus oncology team, etc. So, and Smriti mentioned about psychosocial aspects, which needs to be, more comprehensively assessed, so that we understand a better picture of what is the dynamics between the different family members and the thoughts and the fears and the anxieties. I think, have I missed something, sir? So, Vidya, do you want to add something?
I think you no, man. I think it's okay. Yeah. We can introduce Clara, and then we'll move on to the next case. We are running out of time.
So we are extremely pleased to have Dr. Clara Pisocki. She is our WHO Collaborating Center, that is STIP's responsible officer from WHO Southeast Asia Regional Office. She has been so kind enough to join us during this ECO as a special guest, and she will throw this first ECO session from India in palliative care for the Southeast Asia region, open with some inspiring words from her. Clara, on to you. Unmute yourself, Clara.
Thank you very much. Can you hear me okay?
Very much.
Yeah. Thank you very much for the very kind words. And first of all, I would like to say thank you to Dr. Raj and Dr. Nandini for the invitation, because this is such a privilege actually for me to join you, and just listening, even just this short time, listening into the discussions. It's, when we work in WHO, we often think of policy terms and we talk about the official resolutions and the official discussions with the government, but the real work, what you are carrying around looking after these patients and providing palliative care, this is exactly a wonderful opportunity for me to see and understand that what are the difficulties, what are the issues. We often talk about patient-centered care as a very key element of providing good quality care for patients under universal healthcare coverage, which many government has committed to. But unfortunately, often the very basic element of making patients free of pain, having a good quality life, while whatever conditions they are dealing with, is actually missing, unfortunately, in many of the countries' healthcare system. And that's why I feel that the work what you do is so important, obviously not only for the end-of-life care, but in many other aspects of other conditions as well. And what you will be able to train other doctors and change the attitudes about how pain management, pain relief can be provided and should be provided to patients is absolutely essential for all those things what governments commit, when they say that they want to provide high quality patient-centered care services. I think this this element of palliative care should be one of the very basic, very critical first step, but each country at least should be working on it. We know that it's not an issue of high costs because the medicines that is needed can be made available. We know that there are various barriers in different countries, maybe on the supply chain in some places, but what I'm hearing more often that it's still more the barriers on the prescribers and the healthcare provider side. So I think the work what you do and the way you engage and what you can show as a example, you know, to your fellow physicians and healthcare provider is absolutely crucial, you know, to make some progress in this area. In WHO, you're probably aware, World Health Organization had a resolution and called on to countries and also committed to certain actions 2 years ago in 2014, almost going to be 3 years ago. I'm very keen to work and I'm very happy. I already had a chance to visit Dr. Raj and Dr. Nandini in Kerala, and I just came back from Sri Lanka, where I also met with the oncology team and discussed the progress what they are making on in this area, trying to create a policy framework and build up a training team who can expand this work. I think we have a lot of work to do, and I will be very interested to learn, and this sort of learning what you do and information what I can get, which we can then have to bring to other countries who have not yet started maybe in this area, will be absolutely important. And we did discuss with Dr. Raj and Dr. Nandini potential regional level useful tools or policy models that might be helping other countries. Where India has already revised regulations, you know, maybe some countries will be able to look at that model, you know, how they were able to progress. But I don't want to keep up a lot of the time because I know that it's you are short of time. So I just wanted to say that I'm very happy to be able to join in and listen in, and I will stay online now and just listen into your discussion, and hopefully we will be able to connect and if anything, I can assist on the medicine supply side. I'm mainly dealing with the supply issues. Please do let me know. You can always reach me through Dr. Nandini, and I would be very happy to also individually communicate with any of you. So that's just a little comments from me. Thank you very much. Over.
Clara, we are most honored to have you with us. So thankful that you would come and join us and inaugurate this first session of our first TIPSICO, first time in the Southeast Asia region, first time in palliative care. Thank you so much.
And just as a matter of interest, Clara, we have one more Southeast Asian region country represented here. We have Funsho from Bhutan. So two. Bangladesh, Dr. Bharsana Khan, and Funsho from Bhutan.
Can you just wave and show
Farzana?
hands. Actually, Nepal also wanted to join, but the internet connection did not permit them to come into the ECO program. And Dr. Krishna, even the Delhi team could not work it through. Otherwise, we would have had one more country. On to you.
Yeah. Thank you, Dr. Clara. And can we move on to the third presentation by Dr. Abhishek? Abhishek, are you ready? I'll share the screen. Can you see? No?
I can see.
Yeah.
Good afternoon, everyone. I'll be talking about recently, which I have gone through a case like this is a 7-year child who has been diagnosed with osteosarcoma in December. He underwent amputation. Post amputation, his complications like the headache and diplopia started. It happened like he was normal. He was fine till January 2016. When suddenly the parents noticed swelling in his left leg. They approached the local doctor, who then referred the patient to Nagpur Medical College. There, unfortunately, the biopsy report which was there of the swelling did not diagnose osteosarcoma. So the child again went back home, but when the swelling started, the parents were concerned, and then they moved to All India Institute of Medical Sciences. By the time they reached AIMS, the swelling was such a huge and was profusely bleeding that even without the biopsy report to come back, the child underwent amputation. The biopsy report came later on. The child was like, after post-operative, there were no complications, but suddenly
Turn off, no TV.
10 to 15 days post-amputation, the child started complaining of headache, severe headache and diplopia. I started him on morphine, low dose of morphine, like 2.5 mg 4 hourly, but there were no relief. So we suspected the metastasis, which has, because of the tumor was so huge, we suspected metastasis. So we advised, like, the treating doctor, we contacted the treating doctor, and we advised for the future course of action. So the treating doctor recommended CT scan chest and MRI brain. The metastasis was diagnosed, and the parents were not in a condition to accept that there is no more treatment, because the child post-operative was very in a good condition. So the parents were not accepting that the disease has metastatized and there is like no more treatment. So convincing the parents about the real prognosis of the disease was a major challenge. Still now they have not been convinced. They are still at our center. They are still searching for the best options, going for other medical therapies. Secondly, getting relief of the headache, like even after, like, we have moved on to 5 mg of morphine with dexamethasone tablets, 4 mg, gabapentin tablets, 100 mg BD. And because of the constant headache, he also complains of nausea. So the medical complications is also not being taken care of because of the headache is not being relieved, as well as the psychological part, like the parents are not being able to convince, like, there is no more active treatment, and the best way is to improve the quality of life of the patient. So they are still searching for it. So these are the two challenges which are coming across this case. One is the complications, the headache and diplopia, and second is the psychological part, that we are not being able to effectively communicate with the patient and convince them that there is no more treatment for this. So this is my concern.
Sir, you want to say something, sir?
Yeah, Abhishek, I wanted to ask Abhishek, can you describe the nature of the headache? I mean, like the way you would describe any pain.
He says it's in constant duration and it's dull aching pain, which starts from the frontal side and it circulates like it's all over the region.
All over the head, constant?
Yes, sir. Yes, sir, constant.
All over the lesion?
All over the lesion or all over the head?
All over the head.
Okay. And you said it was dull. Yeah?
Yes, sir, dull aching.
And is it accompanied, you said nausea, but is it accompanied by vomiting?
No, sir, no vomiting.
I mean, like, I think I will shut up for a little while and listen to other comments and questions before I continue.
Dr. Mary, yes. Unmute yourself. Unmute first.
Is it okay now? Can you hear me?
Yes.
Sorry.
Yes.
Was there a
Yeah.
question? No.
I just wanted to know, what was the MRI like? Was there any circumscribed lesion, and where exactly was it? Because if the headache is not coming down with conservative treatment, what about mannitol? What about removing that? If there's a circumscribed lesion in the head, can't that be removed? Craniotomy.
The MRI report showed like the metastasis is there in the skull, the skull bone, and like
On the bone.
after start,
It's not
yeah,
intracranial.
no, it's not.
Okay, okay, then it's a skull. But is it
And
causing signs of raised ICP?
And generally, like, means I personally would not recommend for a child who has already the disease has been metastatized to go for a craniotomy and other. Uh, I'm not very sure. Means Dr. Rajagopal sir will be able to answer this.
Because the signs of raised ICP are still there. So how do we handle that?
Yeah, exactly.
Dr. Nandini, we are not clear about the site of the metastasis. We are not able to understand where in the head is the metastasis, and also the weight of the patient, because we want to check whether the dosages and the weight, they match. So can you tell more about the site of the metastasis? We want to understand the propia, the reasons, etc.
The site of the metastasis, the report, MRI report is not with us. It's with the treating hospital. So it was just written that there is a bony metastasis there in the skull, and the weight is 24 kg of the child.
What is the weight, Abhishek? We didn't hear it.
24 kg.
24, sir.
I'm still holding myself back. Maybe there are more questions or comments.
Dr. Parvin, you can speak.
Thank you, ma'am. Two things. One, I wanted to know, was there any effect of morphine? Like, did the pain reduce? And second thing is use of corticosteroids, because here this bony metastasis. So is morphine helpful in headache? This is actually my open question. Is morphine helpful in such headaches? And if it was helpful, then why did we stop us at 2.5 milligram per hourly? And role of steroids, are we giving them?
The child is getting 8 milligrams of dexamethasone every day.
That comes to 0.3 milligrams per kg, and that is a good dose. That's the allowed acceptable dose, 0.3 milligrams per kg.
Morphine has been increased to 5 milligram per vein, for your information. And Farzana wants to ask a question. Can you, Farzana?
Yes, thank you. Actually, I was wondering whether we can build up with gabapentin more. We can increase the dose of gabapentin every 3 days. And while building up the gabapentin dose, can we introduce injection ketamine orally to this patient? Thank you, sir.
Farzana, if I may ask a question, clarify from your question. Were you thinking of a neuropathic pain in this case? Is that why you suggested gabapentin?
Yes, sir. I think this is more of a neuropathic pain, because this is my feeling. I'm not sure, because I could not see the MRI or thing. But I think this is more of a neuropathic kind of pain the child was suffering from.
Farzana, I would doubt that statement, because the two possibilities we have, major possibilities we have, is on the bony pain from the skull mets. And I think most of the treatment has been geared to that. The second possibility is one of elevated intracranial tension, which typically would have vomiting, but not necessarily. And the fact that the child is not vomiting still warrants a second look at the MRI. I mean, I find it very distressing, a huge ethical issue in this country, that people are made to pay for their MRI scan and not given out the films. That's our property, the hospital say, and however big the hospital is, that is clearly unethical. And they have a right to have the reports. And it is something that we all must fight for someday. But Abhishek, I think it's very vital as we work very closely with the hospital to
Yes,
get
sir.
clear that. Now, as Nandini said, if it's only a skull match, you have given enough corticosteroid. But if the person doesn't need to have a elevated intracranial tension, you may go far higher, even up to 2 milligram per kg or at least 1.75 milligram per kg. Either you titrate up or you give a high dose and titrate down. Because if it is elevated intracranial tension, unless we bring it down, no other medicine is likely to work. And I would very much emphasize or underline the earlier question about the response to morphine. You given up to 5 milligrams of morphine, the response was poor. What does that mean? Does it mean that the pain came down for, say, half an hour, 1 hour?
Yes, yes, sir.
Yes. Very clear.
It used to bring down the pain. It used to bring down the pain for an hour. Again, the pain used to be on the same level.
And during that 1 hour, was the child very drowsy, Nandini?
No.
If the pain came down by 1 hour, it's a clear situation where you have to titrate the morphine. Came down only for 1 hour means that the dose needed is going to be much more. Maybe even on a daily dose, you would go up the dose, increase the dose up by about 50% every day till the pain relief continues till the next dose. And to everyone who doesn't know it, I will always emphasize this question. When the response to morphine is not good, and that simple statement is not acceptable. Does it bring the pain down at least for a little while? And if it does, it shows that the pain has an opioid sensitive component and the dose needs to be built in. Personally, I think the chances of neuropathic pain appear to be limited because if it is whether it's skull pain or elevated intracranial tension, it is still nociceptive. In elevated intracranial tension, the pain is caused by stimulation of the receptors on the meninges, not on the brain per se. So maybe that's more likely to be a nociceptive pain.
So the child has diplopia, so there should be some element to intracranial pressure, right, sir? Or a space-occupying lesion in the brain, maybe.
Yes, there are several pointers. One is diplopia, one is nausea, and also if Abhishek could tell us more about the timing of the pain and the fluctuations, it might help more.
Ma'am, it's constant all throughout the day. It's not like particular timing.
Vidya Kumarasamy, when you mentioned the diplopia and something else, were you mentioning them as a possible reason why the pain could be not neuropathic?
No.
Okay.
No, sir. Space-occupying lesion was what I mentioned.
Not necessarily intracranial tension. That could be directly related to the site of the intracranial lesion because there is a tumor. Where is it?
Yes, sir.
I mean,
yes.
Even if you tell me, I wouldn't know whether that's in a position where it's likely to cause tinnitus or a particular symptom. But that is a question maybe a neurologist will be able to answer for us.
So it would be the skull base is involved, etc. So Abhishek, if you could, access at least the report from the earlier hospital and probably bring it up during the next echo, during that little bit of time, it would be helpful.
And Abhishek,
one more. Yes, sir.
If it does show elevated intracranial tension, or if there is a reasonable suspicion, you keep going up on the dose of dexamethasone significantly. For a 24 kg child, I would say at least up to 40 milligrams you will keep going. True, it will cause side effects, but high doses may have to be given. Such high doses may not be easily tolerated orally, so you may have to go parenterally, and parenterally, that higher dose may have to be given as an infusion at a rate of not more than 1 milligram per minute. Anyone who gives dexamethasone parenterally, remember this rule, the speed of infusion. I'm not saying this from the Oxford textbook, but it only says slow, but it causes significant adverse effects if it is too fast. So I find that if you limit it to 1 milligram per minute, then that's slowing. So if you are giving 40 milligrams, you give an infusion over 40 milligrams. It can be a subcutaneous infusion also, but the site may have been changed every other day. Or if the suffering is severe, it's permissible to start with 40 and then bring it down gradually day by day till you find a dose that is just enough to control the pain, the headache. But all this is only if the cause of the pain, the headache is elevated intracranial.
Is anyone else wanting to?
Abhishek, you want to ask? Yes, sorry. Abhishek, you want to clarify something?
Yeah, sir, I just like you told that the dose of the morphine might be not adequate, but when we went from 2.5 to 5 mg, then also the headache is still there. So does it still bother about the dose of the morphine?
Yeah, when you bend it up to 5, will the pain still come down for some period of time? Hour and a half?
Yes, sir.
So then the dose
So we can try. Sorry, why not morphine trials to determine the dosage for the child?
The parenteral titration, Vidya?
Yes, sir. Parenteral morphine trial, which we do every 10 minutes. You know.
Which is what you have seen done by us regularly all the time. We are just, and I personally was hesitant to talk about it because it's not necessarily a first line textbook description, but we always, I mean, why not try it and see? The only objection in this particular situation, Vidya, if it is serious elevation of intracranial tension, a high opioid dose could be a significant factor causing respiratory depression. So in this case, if I try opioid titrations, rather than try that every 10 minutes, I might either make it every 20 minutes or something like that, just to make sure that the combination of elevation of intracranial tension and the parenteral opioid does not contribute to respiratory depression.
Thank you, sir. Parveen, you want to ask something? Dr. Parveen. Yeah.
Very much you have partially answered my question. I want to clarify this, like, can we go for full dose of morphine in such type of lesions in brain, if it is there? Otherwise, I would have gone for oral titration, oral trial. And second, I wanted to know, like you said, what is the maximum dose of dexamethasone that we can give to any patient, basically?
I did not quite hear the early part of the first question. Let me straight away answer the second question. Only in this one indication, elevated intracranial tension, the highest dose recommended would be something like 100 milligrams of dexamethasone in a day, the highest possible dose. I am not aware of any other indication where that high dose is given. 100 milligrams for an adult, and in a child, I was recommending up to 1.75 to 2 milligrams per kilogram per day as the maximum.
And the first question, can you repeat, Parveen? We didn't hear it.
Ma'am, because of what we say respiratory depression, if in cases of headache, should we go for highest dose of morphine after titration, or we should keep it lower than the highest possible dose?
Possible dose per week is the dose required to relieve the pain. And as you are
Yes, sir.
you are looking not only for the relief of pain, but also for drowsiness. And in this particular case, the respiratory pattern will tell you whether it's acceptable or dangerous. Just if the respiratory rate is not dangerously low and the pain relief is good, I would continue the dose like in any other patient.
So Dr. Vidya Vishwanath wants to say something.
This is very basic, but why are we not considering paracetamol at all?
No. Not mentioned.
No.
Just with one question, Vidya Vishwanath has brought us all down to ground zero. We were all thinking of weird, high-flown things. Maybe the simple thing is what we should try first, and paracetamol. Absolutely, Vidya. Thank you very much.
Thanks, Stefan.
Yes, feet firmly planted on the ground. But Stephanie, you mentioned that non-steroidal anti-inflammatory. When you are giving a high dose of dexamethasone, maybe that would be tricky, but you would consider that. Yes. Thank you, Vidya.
So especially if it is a bony pain, it would go more in favor of adding step 1 drugs rather than increasing the higher dose of Dexona. But if it is more in favor of raised intracranial tension, we would follow what Dr. Rajagopal instructed and use the dexamethasone drug along with the titration of morphine. Patient is stopped taking all kinds of disease modifying therapy as of now, right? Abhishek?
Yeah.
But the patient had a radiation to the skull.
Not after it. Only the amputation.
No.
Okay, so if it is elevated rectal tension, we go that route. If it's a skull bone metastasis causing the pain, we would still reconsider the palliative radiation.
Okay.
Thank you, sir. So to summarize,
The second, there's a second section to the question. Is there something more that Abhishek you want to discuss?
Yeah, the second part of the question, the psychological assessment has not been covered. Like I asked about how to deal with the parents. They're not accepting it. They only considered about the medical part.
Was it the question that has already been dealt with in the last patient story? Something that Swati want to expand it on maybe? I mean,
But see,
you
parents here.
Previous patient Abhishek, arising from that, any further question or clarification you would have?
No.
When Bill Shiva came up with that question of a child and a family and the counseling, wouldn't all that apply to your patient and family also?
Yes, sir.
So to sum up the current case discussion, we would very much like to know the site of the metastasis, because that all the discussions, showed that by knowing exactly where it is, whether it is bony predominant or is it some other reason, we can modify our management accordingly. We very much recommend step 1 medications, paracetamol in any diagnosis, and NSAID, especially if there is a bony metastasis predominantly. Dexamethasone, sir suggested as if at the present he is receiving 0.3 milligrams per kg, this child. This can go up if it is a raised intracranial tension, it can go up to 1.75 to 2 milligrams per kg. That is almost like 40 milligrams per day. And this has to be given as infusion and at the rate of not more than 1 milligram per minute. And we need to re-look at the morphine dose. Currently, since he has at least a transient response to the morphine 5 milligrams, we may consider a trial and trying to understand if there is a dose of morphine which will adequately manage the pain without having unbearable adverse effects. And palliative radiation is very much an option if the patient's dominant metastasis to the bony part of the skull. Otherwise, psychosocial evaluation, as we discussed in the previous patient, and I think in most of the patients it will keep coming up, so we will keep bringing up the psychosocial aspects and family interactions, maintaining, engaging with them, and that will be. So, Vidya, since we have just few minutes left and all the cases are over, is there any announcement that you want to make, or do you want to look at the descriptions and just quickly go through them for their relevance, because we didn't do it systematically for each patient. Of course, we discussed what should be done, but we didn't look at the description and say, is there any point in this particular, because that is something that we decided we will do.
Yes, ma'am. But maybe this week we will send it by email to everyone, our recommendation and what we noticed and everything. Maybe we can just open the floor for any general questions, if that is okay.
Can we do it like, can it be an assignment?
Yes. Yes.
Take the descriptions as they are given in these 3 patients and let the group come back with what modifications or the relevance of these drugs are, and then that will be an assignment to them. Is that, that a good way?
Yeah, I can send an email with all the prescription details, and maybe we can get a feedback from the group, discussion wise. Yeah, that can be the assignment. Yeah. And can I open the floor for any general questions, like did you face any difficulty or
experience? Yeah.
Yeah, experience with the eco session. Yeah, Abhishek.
It was a wonderful session and very helpful, and I hope with coming more of the sessions will be more like enlightened with other good cases.
Thank you, Abhishek. Anyone else want to share?
Did anyone face any difficulty throughout this session? We would like to know any audio or video quality.
Yes, sure.
From Bhutan. This is the first ever, and then along the session, my dean was peeping in through my office door, and he was very happy seeing that these things are coming up in the university. This is the first time, in fact, and I'm also still very cannot. The excitement has still not seeped in yet. Still feeling excited. And then yes, today's session was very, helpful for me, especially the lecture by Dr. Rajagopal, and on the pain management, the case discussions, especially about the medication part, which is still a little bit of high level for me, being a nurse, but still I could recollect on the classes in Trivandrum last year. I look forward to the next session. And the internet system was, the sound system, everything was very clear. Thank you very much. Team ECO also.
Thank you.
Thank you, Hunsho. I think Dr. Dinesh Kumar and Mayank said they had some difficulty with the audio system. They weren't able to hear, and Dinesh Kumar was saying repeated disconnections were happening. Maybe it is from their side. I'm not sure. I'll ask Kushbu to look into it. Anyone who has faced similar problems, maybe you have to contact Kushbu regarding that. Ma'am, you want to say something?
I think we must all remember somebody sitting far away in USA. If he's still at the moment not traveling around the globe, Sanjeev Arora, a wonderful person who has caused this revolution in information sharing, who thought up the whole idea of using technology, who also had enough management skills to make it happen effectively. So Sanjeev Arora, I wish you could project a picture of him. Sunil, I am sure you will convey to Sanjeev our greatest admiration and gratitude. And to you also. You have been with us all the way. And without that kind of support, we would have taken centuries to come to a practical solution for many problems. And of course, Vivian, you have been wonderful. And Nandini, at my speed, this would have reached a very ineffective conversion about 2 years. Thank you for pushing everybody and making it actually happen with that efficiency. And everyone, honestly, it is such a delay to meet each of you. We get the chance to meet up maybe once in several years. And here you all are. Thank you very much. So, thank you, Manoj, for that. That is Sanjeev Arora.
Are you able to share screen?
Can I have a small word in here? First of all, let me congratulate you all. I've attended loads of tele-echo clinics here. This is probably one of the best. Considering it's the first one, I think it went absolutely brilliantly. Really, Dr. Rajagopal and the team and all the participants, thank you very much. I noticed you're recording it. Please do send us the recording, and I'll share your the screen with Sanjeev and let him know that you were very happy with it. And thank you very much. We really appreciate your participation. Thank you again. I must applaud you all for a wonderful clinic. Thank you.
Thank you, Dr.
We are so pleased and so encouraging that you could take time out to be with us. Thank you very much. You've always been supportive since you came into this country last year. Thank you very much.
And I take some time to thank every center that came in. This ego is possible only because of all this collective cohesive efforts, and we are all learning together. We learned so much from you today, and it's so wonderful that you just responded to our invitation, and we have really made this happen. Thank you so much to every center.
Dr. Clara wants to say something.
Project Dr. Sanjeev Arora's photograph.
Yeah.
Are you all able to see it?
Can I just go ahead?
Yes.
Just wanted to say again also a big congratulations to the whole organization of this event. I just feel it's a wonderful feeling. I feel like I've been part of an amazing grand round, like we used to do grand rounds during training at the university. This visual electronic technology actually really makes it possible that you can connect really well and have these questions and have this connection. And I think it's a wonderful way of using technology to share your skills, share your knowledge. So congratulations to the organizers and whoever was able to put this together. I think this could be a very, very helpful way of connecting you and sharing and building knowledge and skills in this area. And you probably saw that my director popped in because I was telling her that, look at this, we have to look at in WHO also, we have to use this more with our WHO offices because this technology works so well. But I really feel that, the facilitation and the way you put together the whole program, I think is very, very effective. So congratulations.
It will be very inadequate to finish this talk without thanking Manoj and Vishnu Prasad. Today, if you can just call him inside and you can just say hello. They have been working for nearly 2 weeks to put this room together with the equipment in place, trying to know when to place the camera, with the help of editing, of course, but they have really worked hard to make this happen. Thanks so much to Manoj and
I shared.
Yes,
and
it has been
to
shared.
Vishnu
Sanjeev Arora is, Dr. Sanjeev Arora is on the screen now. I hope you can all see him.
So, Vishnu, just say hi.
Come in front of the camera, please.
So, this is our technical team, Manoj and Vishnu Prasad. Both of them have really worked on the technology, and he's the one who has been opening your mutes and closing your mute and getting the speaker view, etc. We don't know anything about it. They are the ones who are handling all the time.
Manoj is our Tallinn India CEO, and Vishnu is the IT coordinator.
Thank you.
Thank you so much. So, Vidya, we can over to you for the final words.
It was a wonderful experience to interact. I was actually multitasking, so lost a bit of concentration here and there. I think the next session will be much smoother for me, I think. We will be sending an email with the assignment following this session and also some articles for everyone to have a look at. Thank you, everyone. And we will all try to keep in touch, right? Thank you. Ma'am,
the next session is on February 3rd, and it will be again at 2:30. It's a Friday. So, see you all again on February 3rd afternoon. We hope to get more patient discussions for the session. Thank you.
Thank you, ma'am.